Hello, dear doctors. How are you? I hope that all of you are managing very, very well. Sorry, I'm still having residuals of laryngitis. My voice is in the recovery phase. So today we are going to talk about headache. This is our teaching gem for today. Hopefully you don't get headache after we finish the session. Yeah, okay. So let's get started. Before we start, there is a piece of three pieces of information that worth knowing before we talk about exploration of headache or how are we going to deal with the headache cases to reach the provisional diagnosis. All right? What are these three pieces of information? The first one is that headache could be primary headache or secondary headache, okay? The primary headache is the headache which is coming without any underlying disease. There is no disease causing this headache. Yes, there is a trigger for the headache, but there's no underlying disease causing the headache. And the aim of treatment of this headache is treatment of the headache itself by some painkillers. The primary headache, like what? Like tension headache, migraine, and cluster headache. All right? Okay. What about the secondary headache? The secondary headache is the headache which is coming because an underlying disease. There is a problem causing this headache. And the aim of the treatment of this headache is treatment of the cause. The secondary headache, like what? Like anything apart from tension, cluster, or migraine. All right? Let's talk about the second piece of information. The second piece of information is the differential diagnosis or the causes of headache. What are they? When you think about the causes of the headache, please think about this lovely picture. We have a man here. This man is sad because he has headache. We need to search together about the cause of his headache. All right, so let's take this man or this face layer by layer from up downwards. All right? The first cause of headache, especially acute headache, is trauma to the head or the skull, okay? Below the skull, there is meninges. So if there is any inflammation of the meninges, the patient can present with headache, like in meningitis. Sometimes encephalitis can come with headache. Encephalitis is the inflammation of the brain tissue itself, all right? This is in terms of meningitis or meninges. Below the meninges, we have the brain. We have talked about encephalitis, which is the inflammation of the brain tissue. Also, you think about subarachnoid hemorrhage, bleeding inside the brain, space-occupying lesion, especially in persistent chronic headache. This is in terms of the brain. If we go downwards, we have sinuses, the sites of sinuses. Sinusitis can come with headache, all right? Then we can take the eyes of the patient. If the patient has problem in his sight or his vision or increased pressure in the eye, which is glaucoma, the patient can present with headache, right? Then downwards, we have the nose. Breathing carbon monoxide Carbon monoxide poisoning can lead to headache, especially chronic headache. And also this patient can give you a clue that others at home have headache. All right? Downwards, we have the mouth. Drinking alcohol, binge drinking, alcohol hangover. Taking medications can lead, some medications can lead to headache, especially overuse of painkillers. Overuse of painkillers can lead to headache. All right? What else we have? Downwards, we have the jaw claudications, giant cell arthritis can present, the patient can present with headache. All right? So these are the common causes of headache, or the differentials that you can think about if the patient is presenting with headache. All right? So we have finished the second piece of information. Let's talk about the third piece of information. What is it? When a patient is coming to you with headache, please think about the situation. Is the patient coming with headache now or persistent continuous headache? Or the patient is presenting with episodes of headache and the patient doesn't have pain now, doesn't have any headache now? Why is that? It will help us in the exploration. All right? Okay. So if the patient is presenting with headache now or continuous persistent headache, you think about these differentials. If the patient is presenting with episodic headache, you think about these differentials. What are they? What are the differentials? Let's take first the headache now. The patient is presenting with headache now or continuous persistent headache. Okay, the first one is trauma. Trauma can lead to acute headache. Okay, meningitis. Meningitis can lead to acute severe headache. Subarachnoid hemorrhage, stroke, and TIA can lead to headache, acute headache. Increased intracranial pressure or space-occupying lesion can lead to headache, but this headache usually is continuous persistent headache, not acute. Okay? So, continuous persistent headache. Sinusitis. The patient can come to you with headache now, and this headache is sinusitis. All right? Alcohol hangover can lead to acute headache. Carbon monoxide exposure, acute, not acute, we can say it's a chronic headache or a headache for a long while. All right? GCA, giant cell arthritis. In GCA, the patient can present with acute attack of headache. Also, migraine, tension headache, cluster headache can come with acute severe attack. All right? But if we think about it from the exam point of view, usually in migraine, tension headache, and cluster headache, the patient will present with episodic headache. Okay, but you never know. You never know. You might have it in the exam. You might have acute attack of migraine, acute attack of tension headache, or acute attack of cluster headache. All right? Until now, everything is clear.
Yes, doctor.
All right, good, good, good. Yes, yes, yes. All right. Let's talk about the episodic headache. The patient doesn't have any pain now or any headache now. He is presenting with episodic headaches. When you think about them, you think about migraine, tension headache, cluster headache. Also, space-occupying lesion can come with episodic headache, especially in the morning. And this headache is associated with morning vomiting. Sinusitis as well can come with episodic headache. All right? This is in terms of the how to put the differentials based on the situation. And this was the third piece of information. All right? Okay. So how to reach the diagnosis, or how to find out what is the cause of headache exactly in this particular patient, by asking about the other symptoms. In meningitis, the patient will present with headache, with fever, stiffness in the neck, rash, right? In subarachnoid hemorrhage, the patient will present with headache and meningeal irritation as well, neck stiffness and photophobia, in addition to neurological symptoms like facial weakness and arm weakness, right? In increased intracranial pressure, the patient will present with chronic persistent headache, especially in the morning, associated with vomiting. And when you examine the patient, you find papilledema in the fundoscopy. All right? In sinusitis, the patient might tell you, doctor, I have headache and it's increasing when I lean forward, and I do have some nasal discharge. Yeah. Alcohol hangover, the patient will give you a clue that he drank alcohol, binge drinking before the headache. In carbon monoxide exposure, the patient will tell you the others at home have headache as well. All right, these are some clues how to reach the diagnosis. In GCA, the patient will tell you, I have headache in my temple. It's increasing with combing hair or chewing, right? In migraine is episodic headache in half of the head, left or right. There is some triggers for this migraine. It can come with aura before the migraine, and it relieved by sleeping in a quiet room. All right, this is a migraine. Tension headache is band-like headache, triggered by stress, or work, the stress of work, or stress of life. Cluster headache is headache around the orbit. The patient will present with lacrimation, rhinorrhea, and pain in the eye. In space-occupying lesion, we have talked about the symptoms of space-occupying lesion and sinusitis. All right? Okay. Let's move on the next slide. So how are we going to explore the headache, or what should we do when a patient is presenting with headache? We have to think about either this patient is presenting with pain now, or it's just episodes, all right? Once you find this, you will try to explore based on this information. If the headache is now, the exploration will be the same as pain. The headache is pain. You will explore the pain as any pain, all right? If it's episodic, you will explore the episode itself. This will help you to minimize wasting time, all right? To avoid wasting time. All right, so let's explore together. The patient is presenting with pain now. You ask him how to know. You ask the patient, do you have the pain now? Do you have the headache now? Or it's just on and offs or episodic? If it's now, you explore it in the mnemonic Socrates. I don't prefer Socrates, okay? I prefer my way in exploration of pain. It's based on your preference. If you want to follow Socrates, it's totally okay. If you want to follow my way, it's totally okay as well. All right? What is my way? You ask the patient, are you comfortable to talk? Are you comfortable to talk, Mr. X? Then, when exactly the pain started? Why? To know if it's acute headache or chronic persistent headache or what exactly is that pain, all right? If it's acute headache, so you ask about the emergency symptoms, like meningitis, subarachnoid hemorrhage, what else? Giant cell arthritis, the emergency situations or the emergency symptoms. If it's chronic persistent headache, you think about carbon monoxide poisoning or increased intracranial pressure, right? So every question you ask is for a reason. It will help you to reach the provisional diagnosis correctly, all right? Then you ask the patient where exactly the pain. Why you need to ask about where? This will give you a big clue about the cause of the headache. If it's in these sites, in the forehead and in the face, so you think about sinusitis. If it's band-like, okay, so you think about tension headache. If it's in the half of the face or half of the head, you think about migraine. If it's periorbital and temporal, you think about cluster or giant cell arthritis. If it's in the occipital, you think about hypertension and subarachnoid hemorrhage. All right? This in terms of where. Does it go anywhere else? Maybe this pain is radiating to the neck and causing neck stiffness. So you think about meningitis and subarachnoid hemorrhage, right? How did it start? Acute, gradual, chronic? How can you describe this pain? Is it throbbing? So you think about migraine. Is it the worst headache in your life? So you think about subarachnoid hemorrhage, all right? How bad is the pain? Also, you know, if it's 10 out of 10, you think about subarachnoid hemorrhage, okay? You can also ask about the continuity. Is it continuous on and off if you didn't ask this question from the start? Yeah. Anything that makes it better, anything that makes it worse, this will give you a clue as well. Did you take any medication for the pain? If the patient took paracetamol, so you can step up in the pain ladder based on the grade of the pain, the grade of the headache. Let's say that the headache is 10 out of 10. What are you going to give as a painkiller to the patient? You think about morphine right away. All right? Associations. Does this pain associated with hemodynamic instability, like dizziness, heart racing, vomiting? These are the symptoms of subarachnoid hemorrhage. All right? So this is in terms of the exploration of the headache when it's coming now. The patient is presenting with headache now. All right, let's talk about the exploration of the episodic headache. You will explore the episode itself. When did the episode start? The first presentation of the episode. All right? How frequent do you have the episodes? This will give you a clue about the severity. If it's frequent, so this headache is severe. If the patient is telling you, doctor, I have 3 attacks a week of migraine, so this is severe. So you can think about giving the patient preventive treatment, right? The trigger and the reliever, what brings the attack and what relieves the attack. Can you describe the headache for me, please? During the attack, can you describe the headache? This is a smart question, to be honest. Can you describe the headache during the attack? The patient will describe. Is it band-like? Is it in the half of the face? Is it around the eye? Is it on in front of the face and the forehead? Okay. If he didn't describe anything, then you think about the how bad is the pain? Where exactly? Does it go anywhere else? All right. So you think about these, the questions from exploration of pain. If the patient didn't give you any clue about the description of the headache. This is how to deal smartly with any headache station to avoid wasting of time and to show that you understand and grasp headache cases very, very well. Till now, everything is clear. Clear. All right. Good. Okay. So you have explored now. Then you ask about the next question. You ask the next question. What is the next question? Any specific thing happen before having the headache? Or any specific thing happen before the first episode? By exploration, you reach the provisional diagnosis by 50%. All right? If the patient doesn't give you any clue, so you ask this smart question. Any specific thing happened before having the headache? This will give you a clue. All right? Then you ask anything else. Do you have anything else beside the headache? And in anything else, you ask about the differentials. You ask about the differentials. What are the differentials? They are here. Okay? And when you ask about the differentials, you ask about the emergency or the red flags first, and then you think about the other, the differentials. Do I need to ask all of the differentials, Dr. Sahar? No, doctors. It's based on the situation, based on the context, and based on the headache itself. When I teach you the whole structure or all of the causes that you think about, but you pick the important things or the important causes based on the situation. If the patient presenting with headache now, acute headache, severe headache, so you ask about trauma, meningitis, subarachnoid hemorrhage. You don't need to ask about space-occupying lesion. It's not persistent headache. All right? If it's chronic persistent headache, do we need to ask about meningitis symptoms? To be honest, no. Do you need to ask about trauma in episodic headache? No, it's not logic to ask about trauma in episodic headache. All right? So, please think about the situation, think about the context, and then filter your differentials. All right? Okay. This is in terms of the differentials and anything else. After finishing the present history, which is exploration, any specific thing happened, anything else, you think about the other categories of the history taking. The past medical history, the personal history, the psychosocial history, and ICE, ideas, concerns, and expectations. In the past medical history, you can ask about history of hypertension, history of headache before. In personal history, you can ask about personal in chronic episodic headache. Please avoid asking about diet, exercise, smoking, and alcohol in acute severe headache. Again, please avoid asking about diet, exercise, smoking, and alcohol, or you can ask about alcohol in in hangover, but diet, exercise, smoking, please don't ask them in acute severe headache. All right? Don't miss the issue of the case. Psychosocial, you can include it in a chronic episodic headache. What's your job? Who do you live with? Is it affecting your life or not? These questions in chronic episodic headache. Ideas, concerns, and expectations in any single case, in every single case. All right? Finish the history, then you move on to the examination. Just for your knowledge, headache case can come as a non-practical case and can come as a practical case. What does that mean? You might have headache case as a theoretical case. I mean, it's just taking history, verbalizing examination, and giving the diagnosis and management. All right? It can come as mannequin. You find mannequin, endoscopy, okay? You will find the mannequin and you have to examine the arm. You do the fundoscopic examination in headache cases. All right? So once you enter the cubicle, you have to search around, look around. Is there any mannequin or not? If there is a mannequin, so you have to ask important questions in 2 minutes, then you examine and then you manage. Okay, you have to think about the time management once you find out the fundoscopy mannequin. All right? Okay. What are you going to examine in any headache case? If you take the patient from up downwards, you examine the head, the neck, the nerves, vision with fundoscopy. Again, the head, the neck, and nerve examination. Vision, fundoscopy. Okay? All right, doctors? Yeah. This is in terms of any headache cases. How are you going to verbalize it? You tell the patient, okay, Mr. X, thank you for the information you have given to me. I would like now to examine you. I would like to check your observations. Check your observations and examine your neck, nerve examination, vision, your visual acuity, and I will look at the back of your eyes by a specific instrument called fundoscopy. All right? This is how to verbalize the examination. There are no specific investigations in the headache cases, but you have to think about CT scan in acute severe headache. Acute severe headache. When you suspect subarachnoid hemorrhage. Okay, please don't miss CT scan in acute severe headache. All right? Then you manage the case based on the provisional diagnosis. The management includes what we can do to the patient in terms of admission, in terms of referral, in terms of giving medications, in terms of investigations, if there are some investigations. All right? What the patient can do for himself in terms of avoiding the trigger, in terms of making diary if it's episodic headache. Yeah. Then safety net the patient and then give leaflets to the patient. All right? If the case is acute severe headache, then you tell the patient, we need to admit you in the hospital. It's very important to investigate why you have this headache. We might need to do CT scan on your head to find out why you have this headache. And based on the assessment and the investigations, we can treat you accordingly. All right? So this is in terms of dealing with the headache case from the start, from the exploration till the management. All right? Any question till now?
Yes, doctor, I have a question.
Of course, yes.
Yeah, as you told us that we can't go for any investigation, but how could we exclude out the GCA? Because we have to start on treatment, and patient is coming with a severe headache, and we have
Yeah,
to go for the CT and ESR. So
yeah.
how will we go? Yeah.
Yes, you're right. Yes, yes, yes. In GCA, you have to do ESR, and you can refer the patient to the eye clinic to do biopsy. Yes, yes, right. Yes. I mean, in tension headache, in cluster headache, in primary headache, you can't think about specific investigations. But if it's secondary headache, you can think about other investigations. Okay, when I talk generally speaking, but when you have the situation in front of you, you have to think specifically what you should investigate, what you should do. Got me, doctor? Yes, of
Okay.
course.
Okay.
Yeah, good. All right. Okay, so let's talk, or let's do some training. Okay, let's do some training. Let's take the first example. Follow the arrow, okay? Follow the arrow. A patient is presenting with headache now. The patient is comfortable to talk, has this pain since 1 month. It's all over the head, doesn't go anywhere else. It started gradually. How bad is it? It's about 6. How can you describe this pain? Is maybe I can say aching, or maybe I feel like there is pressure in my head. Okay. It is continuous. Nothing that makes it better, nothing that makes it worse, but it's getting worse, especially in the morning. I tried paracetamol, but it didn't help at all. It is associated with morning vomiting and blurry vision. All right? Nothing specific happened. In anything else, when you ask about the other symptoms, I will give you positivity for blurry vision and vomiting. Past medical history is negative. Nothing is positive in the personal life in terms of diet, exercise, smoking, and alcohol. Maybe I can say that I'm eating everything. All right. It's affecting me a lot, especially in the morning. I can't do my housework. I want to know what's going on. On examination, when you do the fundoscopy, you find this picture. Yeah, let's see your answers. Raised intracranial pressure, right? No history of trauma, Dr. Asma. Increased intracranial pressure. There is one of the doctors told me idiopathic intracranial hypertension. Why did you say specifically, Dr. Karen? Idiopathic intracranial hypertension. Opinion or your explanation, please. Increased intracranial pressure, yes. The picture is papilledema, idiopathic. Why you say idiopathic? This is my question. Idiopathic. Why you say idiopathic intracranial tension? How did you know that it is idiopathic? Do you know what is the meaning of idiopathic, doctor?
Yeah, because raised intracranial pressure can be due to brain tumor as well, space occupying
Yeah.
lesion.
So you can't say idiopathic unless you exclude the other causes, right?
Yeah.
Okay. So your diagnosis should be increased intracranial pressure. All right. Increased intracranial pressure. this pressure or this increased pressure could be due to space occupying lesion, and you are going to exclude it by CT scan. Could be idiopathic without any cause. But how are you going to know that it is idiopathic? By exclusion. All right? Got me, doctors?
Yes, yes.
Doctor, I have a
Clear?
question. Doctor, I have a question. Dr. Saham, if the patient, if we go for the examination and we see the papilledema, right?
All right.
But when we going back to the taking the history, the patient tell us that she get relieved when she stand up
Okay.
once, and she is on COCPs for the past 10 years,
Mm-hmm.
and she has got hypertension.
Okay.
Then
So what is your
when we
question
come to the
exactly?
then we have to, for the definitive diagnosis, do we
Mm-hmm.
have to say basal intracranial pressure, or do we have to say idiopathic intracranial hypertension? My question is, do we have to say that just it's a raised intracranial pressure because of the papilledema we saw the picture, or when we're gathering the data, we found all the positive thing along with papilledema, so we have to make the diagnosis that is idiopathic raised intracranial hypertension. What we have
Okay.
to say in the definitive diagnosis. I want the clarification. Thank you.
All right. I got your question. So with the positives that you have told me, you are asking, do I need to tell the definitive diagnosis idiopathic, or I can say it is increased intracranial pressure, right? This is your
Yes,
question.
doctor. Yes,
Yeah.
yes, yes.
Okay. Even with all of these positives, you will tell increased intracranial pressure. You still don't know what's going on. Did you do CT scan? Did you do confirm that there is nothing in the brain causing this increased intracranial pressure? You have to investigate. You can't give definitive diagnosis without three complementary things: history, examination, and investigations. Okay? In some cases, yes, you can reach the diagnosis without investigations, but in this case, you can't. You can't. You are unsafe, doctor, to be honest. In this case, if you don't do the CT scan, I'm really sorry to say that. Okay? So you tell the diagnosis as we discussed. You might have an increased intracranial pressure, because when I found or when I examined the back of your eyes, I found edema or swelling in the back of your eye. And this is a kind or a sign of increased intracranial pressure, increased pressure in your head or in your brain. We are pretty unsure what is the cause exactly of this increased intracranial or increased the pressure in your brain. It might be related to a kind of growth in the brain. All right, I don't say that you have this, but we have to exclude that. It could be something else, which is called idiopathic. Idiopathic means that increased pressure in the brain without any cause. Okay? This is how to give the diagnosis. This is how to show that you have a very good explanation. You can give credibility to your diagnosis. Also, you are safe. All right? Okay. I hope that helps. All right. So let's do the next case. Focus with me, please. All right? Yeah. A patient presenting with episodic headache. He doesn't have any headache now. Follow the arrow, okay? Follow the arrow. Episodic headache, doesn't have any pain now. The headache started 1 month ago. The frequency is 3 times a week. What is the trigger? The trigger is the work. The reliever is the painkillers, paracetamol, ibuprofen. How can you describe? It's a band-like headache. Any specific thing happened? Nothing specific happened. Anything else? Nothing else. In the past medical history, negative. The personal history, we can say that the patient is drinking occasionally alcohol. This headache is affecting him because he has started to have more frequent attacks recently. His concern, he wants to do a CT scan on his head because he's afraid of having tumor or cancer in his brain. Examination is normal. Nothing is, it's unremarkable. What's your diagnosis, doctors? Yeah, tension headache. Good. Tension headache.
Headache, yeah.
Right. Tension headache. Tension headache. Yeah. All right. Good. So, did you find that exploration and going systematic in the exploration will help with any case? You will reach the provisional diagnosis. But if you are systematic and to the point, all right? Okay, the last example. A patient presenting with headache now. He's in severe pain, okay, but he's comfortable to talk. He can manage to talk. It started yesterday. Where exactly? All over the head, especially the left part of the head. Doesn't go anywhere else. Maybe has some sort of neck pain. How it started? It started, suddenly. How can you describe? It's throbbing pain. How bad is the pain? It's the worst headache in the world. The worst headache I had before. It's continuous. Nothing that makes it worse, nothing that makes it better. I tried paracetamol, ibuprofen, didn't help at all. No associations, nothing specific happened. In anything else, I can say that I do have neck pain. I don't have any fever, no rash. I have some photophobia. Okay. Past medical history, I do have hypertension and migraine. Hypertension and migraine. Okay. Personal history is not proper to ask. Psychosocial as well. You don't need to ask here. My concern is I want to know what's going on. On examination, nothing is remarkable. So what is your differential, or what is your diagnosis in this case? Let's see. Subarachnoid hemorrhage, CT scan, lumbar puncture, okay. Subarachnoid hemorrhage, okay. Could be something else. The patient has migraine, could be something else. Hemiplegic migraine, maybe migraine, yes. So you can give differentials here. It could be severe attack of migraine. It could be subarachnoid hemorrhage. How are you going to exclude this or confirm if it's migraine or subarachnoid hemorrhage? CT scan, all right? This is how to explain to the patient. Please don't give specific diagnosis if you have differentials, okay? You tell the patient, all right, you have this pain since yesterday. It's the severest headache in the world. Also, you have neck pain. You have a history of high blood pressure. In addition to that, you have history of migraine, okay? So what I'm thinking about is mostly two things. The first one is severe attack of migraine, but we can't miss one of the emergency symptoms, which is bleeding in the brain. I didn't confirm that you have this, but we have to exclude that, all right? So to exclude that, we will need to admit you in the hospital and do CT scan on your brain to find out, do you have any bleeding, anything serious in your brain? And then we can take it from there. Do you have any problem in admission? Do you have any problem in doing this CT scan? With playing of your facial expression, with playing of your tone of voice. Please don't scare the patient. Don't scare the patient. Okay? Don't tell the patient, okay, I'm afraid that you have bleeding in your brain. I'm really sorry to hear that. Unfortunately, it is a serious problem and we need to admit you and we need to do. No, 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 no. Don't do that. Explain the situation, show the urgency, but in the middle, reassure the patient. Got me, doctors? Okay. Any one of you can do a station, a small station with me. Okay. Dr. Marwa. Okay, so you have 1.5 minutes. I will um, tell you the question and then we can start after 1.5 minutes. You are an FY2 in the A&E, Maria Thompson, 35 years old, presenting with headache. No additional information. Please talk to the patient, assess the patient, manage her, and address her concerns. Okay?
Okay.
Talk to the patient, assess her, manage her, and address her concerns. These are your tasks. No additional notes. Start.
Okay. Hello, Doctor. This is Dr. Marwa. I'm one of the junior doctor in the emergency department. Am I speaking to Miss Maria Thompson?
Yes, Dr. Maria Thompson. Yeah. Yes,
Hi,
doctor.
Maria. Okay. May I just confirm your age, please?
I'm 35, doctor.
Okay. I can see from my notes that you're coming due to a headache. Am I right?
Yes, yes, doctor. I have headache. Yeah, I have
Okay.
headache,
Okay.
severe headache.
All right. I'm so sorry to hear that. Are you comfortable to talk now, Maria?
I can manage. Yes, doctor.
Okay. And do you still have the pain now?
Yeah, I'm still having the pain. Yeah.
Okay, I'm so sorry for that. All right, so can you just tell me more about this pain so we can manage it in a better way?
Yeah.
So, yeah, so can you tell me when did this pain started?
Yesterday, doctor.
Okay, and how did it start?
All of the sudden, doctor. It started all of the sudden.
All of a sudden, okay. And does it go anywhere else?
It's all over my head.
All over your head, okay. And how bad is the pain? Like, if I tell you from 1 to 10, how bad would you rate it?
It's the severe headache in my world. Yeah.
Okay, okay, okay. I'm so sorry to hear that. And how can you describe this pain? Like, what's the nature of the pain?
I don't know. I don't know, doctor. I don't know.
Okay, okay, no problem, no worries. Is it continuous?
Yeah.
Like it's not stopping?
Yeah.
Okay. Anything that makes it better? Do you feel like there's
Nothing.
something? Nothing. Okay. And anything that makes the pain worse?
Nothing.
Okay. Have you taken any medication for this pain? Any pills or anything to relieve the pain?
Ibuprofen. It didn't help at all.
It didn't help. Okay. There's any specific thing that happened prior to the pain?
Um, I found some flashes of light because I have migraine already.
Mhm.
Yeah, I thought it's migraine attack, but I don't know, doctor. I don't know. I feel like it's severe. It's very severe.
Okay, I can understand. I can imagine how difficult this might be. But how you told me that you have migraine. How frequent are the attacks?
Maybe once a week.
Once a week. Okay. And do you take any regular medication for that?
Yeah, I'm taking. Yes, I'm taking propranolol. Yeah.
Propranolol. Okay, okay. And you told me about you felt like the light was irritating you, right?
No, flashes of light before having the attack.
Oh, you have a flashing of lights. Okay,
Yeah.
okay. And anything else? Do you have any fever? No.
No,
Any okay. Any neck stiffness?
no.
Okay, okay. That's quite reassuring. Okay. Do you have any medical health conditions generally?
I do have high blood pressure and migraine.
Okay. Okay. And do you take medication for that, for the high blood pressure?
Yes, I'm taking amlodipine.
All right. Just a few questions now about your regarding your lifestyle. Are you facing any type of stress recently?
Stress. The
Yeah.
usual stress for anyone, doctor.
All right. Okay. And how's your diet generally? Or how's your lifestyle generally? Following a healthy lifestyle?
Yes, yes, doctor.
Okay, that's good. That's good. And regarding do you take any contraceptive pills?
No, doctor.
Okay, okay, that's reassuring. Any chance that you might be pregnant?
No.
Okay, okay. And how do you feel that this headache is affecting your day-to-day activities?
It's just started yesterday. Since yesterday, I didn't do anything in my life. I just
Uh,
sit down with this severe headache.
yeah, that must be very worrying. I can understand that. And what do you do for a living?
I'm a housewife, doctor.
Okay, okay. So, all right, thank you, thank you. I would like just to know, like, do you have any idea what might be causing this pain?
No, doctor.
Okay. Any concerns beside the pain? Other concerns?
No, and I just need to anything to relieve this pain.
Okay, okay. Don't worry, we are going to help you. We're going to even like treat you and give you the right medication to decrease this pain. So thank you for answering my questions. I'd like now to examine you, check your observation, check your blood pressure, right? And would like to examine your head, nerves, vision, and also the back of your eye by a specific device.
Mhm.
All right. Thank you. Thank you for
Blood
letting me
pressure
in.
is 160 over 90, and nothing else.
Okay. Okay. Thank you for letting me examine you. As you told me about the pain that you're experiencing, and I'm a little bit concerned because of the severity of the pain, and especially when I checked your observation, I found out you have a high blood pressure.
Mm. What do
Yeah.
you mean, doctor? Why you are
So
concerned?
so sometimes when the severity of the headache and when you have a very severe headache and you have a high blood pressure, this is actually could be like a concerning sign for me because it might be something due to bleeding inside the brain.
Oh my God, bleeding in my brain.
Yes, I know it's shocking and you didn't expect to hear something like that, but it's just because I'm really like concerned and this might be serious.
Oh my God. So, yeah,
Yeah,
what,
but
what are you going to do now, doctor?
all right. So regarding our management plan, I'll first thing that I want to do that to stabilize your blood pressure, right? Going to give you some medication to lower your blood pressure. Going to involve the neurology team. Okay. Do you like
Mhm.
to know what they might do for you?
Yeah, yes, please, doctor.
Okay, so the neurology specialist, they will do a type of CT scan on your head, all right, to know what exactly and to rule out any serious causes. Okay,
Okay.
and we will also take some bloods as well. All right,
Mhm.
and
Okay.
yeah, and would you like to call anyone from your family?
No, no, doctor, I'm fine. I'm fine. I just need to know after the CT scan, I will call them. I just want to
Okay.
wait. Yeah.
All right. All right. So don't worry, we're here to help you, and we have a team of experts, doctor. They're all here to help you and manage your condition in the best way. So also after stabilizing you in the hospital and after getting discharged, hopefully, you will be we will arrange a follow-up for you. Okay.
Okay.
So do you agree on this plan?
Yes, yes, doctor. Yeah.
All right. Okay.
Time's up.
Thank you.
Time's up. Okay, thank you, Dr. Marwa.
Thank
So,
you.
how do you feel?
Uh, no, not so bad, but I felt like I missed, I forgot some important questions I didn't ask about.
In general, you've done it well, okay. But
Mhm.
why did you tell me it's only subarachnoid hemorrhage?
I said it's only subarachnoid hemorrhage.
Yeah, you didn't tell me it could be migraine.
Oh, yeah. I should have said that, right?
Yeah,
That it is
yeah. It's one of the differentials.
one
Migraine
of the
can
different.
come.
But
Okay.
doctor, when you said the high blood pressure, then yani, immediately I thought about the subarachnoid.
All right. Okay. Even if there is no blood pressure, if no high blood pressure, okay. Just to let you know, doctors, in the hospital, I found one of the patients. She came with the severest headache in the world, with symptoms of facial weakness and dropping of the face, dropping of the left part of the face. All right. She came in the hospital, and we took the history, done the history with her, examined her. We found these things, neurological symptoms, and then we had to do CT scan. Okay, the CT scan is normal, and the diagnosis was what? Severe attack of migraine. Migraine can come with neurological symptoms. Migraine can come with severe attacks. All right. So think about differentials. Don't give one differential. All right?
Yeah.
Okay. So let me share the screen. I will show you what you did, what you missed, and yeah. Okay. So the patient is presenting with headache now. You explored the pain very well. Are you comfortable? When did it start? Where? Anywhere else? How? Is it continuous? Any medications? Maybe you didn't ask about association. I mean, vomiting, hemodynamic instability. If the patient is presenting with severe headache, the worst headache in the world, so please don't miss dizziness, vomiting, and sweating. Okay? Hemodynamic instability. All right? Any specific thing happened? Anything else? In anything else, I think you asked about fever, right? And neck stiffness. Did you ask me about facial dropping or any neurological symptoms?
No, I missed that.
Okay. You didn't ask me about any facial weakness or arm weakness. Okay. Neurological symptoms. Okay. You can ask also about vision. Do you have any vision problem? Do you have any pain in your eye? Okay. These are the things that you can ask in this case. I think you asked about trauma. I can't remember. You didn't. You didn't ask about trauma, right?
No, I asked.
Yeah. So take it layer by layer. Trauma, fever, neck stiffness and rash in meningitis. Meningeal irritation and subarachnoid hemorrhage can be present in addition to facial weakness and arm weakness, please. Neurological symptoms. Okay? Then you move down to the eye. Any vision problem, any pain in your eye, and that's it. These are more than enough in this case, in this particular case. All right? Then you asked me about the past medical history. To be honest, personal history in this case is not important at all. Skip it. Don't ask it, please. Severe headache and acute severe headache is inappropriate to ask about personal history. All right? Diet, exercise, smoking, and alcohol. So if you ask me, it would be better to ask about facial weakness and arm weakness and eye pain in addition to the trauma instead of asking about personal history. Okay?
Yeah.
Got me?
Yeah.
Also, you asked me about stress. Why stress?
Because I thought about migraine at the beginning.
Okay. All right. No worries. Yeah. Okay. Then psychosocial and ideas, concerns, expectations. Then you examined me. Well done. So you missed few questions in anything else. Then you asked about COCPs and pregnancy. Well done. Okay. And after that, you told me the diagnosis. The way you gave me the diagnosis was very good. You've done it really well. But I would love if you just tell me it could be severe attack of migraine. The good thing that you came, so we can investigate, we can search what is the cause, and we can treat you accordingly. All right? You gave me subarachnoid hemorrhage only, so please give differentials in this case. This is the first thing in the management. The second thing, you told me that you are going to admit me. Ask me, do you have any problem in being admitted? Or do you have any problem in doing the CT? Involve the patient, please. Involve the patient. Don't give facts to the patient. Got me, Dr. Marwa?
Yeah.
All right?
Mm-hmm.
Then what is the management? Admission, treat the high blood pressure, right?
And neurology.
Then CT scan and neurology. And then if you have time, as you had in the station, you can tell her, all right, we can, after that, we can talk about controlling the blood pressure and the medication that you are going to take and follow up appointment. Okay?
Okay.
These are the main points in your management. Your management was okay, to be honest, but please give me differentials, right?
Okay. Thank you.
Yeah. Thank you, Dr. Marwa.
Thank
Keep
you.
it up. Yeah. 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 Okay. Thank you, doctors. Thank you for attending, and thank you for listening. I hope that it was helpful. Was it helpful, doctors?
Yes, very helpful. Thank you so much, doctor.
Okay. Thank you. Good. Good, 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 good. All right. Yeah. All right. So in the next session, inshallah, we are going to do mock on headache cases. Please prepare these cases, the cases that we have talked about, these ones. Prepare meningitis, subarachnoid hemorrhage, increased intracranial pressure, sinusitis, alcohol hangover, all headache cases. Prepare them. And we are going to do 4 or 5 as the time allows us on headache cases. All right? Okay. Thank you, doctors. And see you in the next session. Bye-bye.